Welcome to our latest deep dive. Today, we're talking about a bacterium that's really forcing its way into the spotlight in clinical microbiology, Corynebacterium Macginleyi. We've used a Gemini deep search to really unpack its story, because it's a fascinating one, from what we thought was a harmless bug in the eye to a serious hospital-acquired pathogen. So, let's just start here. This is Corynebacterium Macginleyi. For a long time, it was pretty much ignored, just another commensal. But as you're about to see, that story is changing, and it's changing really, really fast. I mean, just look at this transformation. When it was first described back in 1995, we all thought, okay, low virulence bug, just hanging out on the eye, no big deal. Fast forward to today, and the picture is completely different. It's now a significant, often multi-drug resistant pathogen that can cause some really severe systemic infections. This whole shift, it's happening because our diagnostics are finally good enough to unmask what this thing is truly capable of. Now, everything we're covering today comes from a synthesis of dozens of research papers. And for those of you who really want to get into the weeds, the full notebook with every single source is available. You can check it out and explore the data for yourself. Okay, so where does the story begin for us in the lab? Well, it starts right at the bench. This is where we get our first clues and also our first major headaches. So you get it under the microscope, and it looks like a classic Corynebacterium. It's a gram-positive, club-shaped rod. You might even see those telltale Chinese letter arrangements. But here's the thing. Looking the part is easy. The real challenge is figuring out exactly which Corynebacterium you're dealing with. In this right here, this is its calling card. It's lipophilic. It loves lipids. On your standard blood agar, the growth is pathetic, slow, tiny little colonies. But look what happens when you feed it what it wants. You add a lipid like Tween 80 to the media, and boom, the growth just explodes. You get large, robust colonies, and sometimes even this really distinctive pink color. That's a huge clue for any lab trying to isolate it. All right, so you run your biochemicals maybe on an API Corynus strip, and the single most important result you're looking for is this one, the negative pyroxenamidase test. That one little reaction is a major fork in the road in your identification algorithm. It immediately separates Corynebacterium Macginleyi from a whole bunch of its relatives. And that brings us to the main event when it comes to identification. How in the world do you reliably tell it apart from its closest cousin, Corynebacterium accumbens? They are so similar, both biochemically and genetically, that it creates a massive diagnostic headache. Now, here's the trap. Your lab workhorse, 16S RNA sequencing, is going to fail you here. The sequences are just too similar. It can't tell them apart. If you want a definitive, rock-solid answer, you have to sequence a more variable gene. And today, the molecular gold standard for that is the RPOB gene. Of course, the real game changer, the reason we're seeing so much more of this bug, is MALDI-TOF. Mass spectrometry gives you that rapid protein fingerprint for identification. But, and this is a huge but, it is only as good as your reference library. If Corynebacterium Macginleyi isn't in your database, you're either going to misidentify it, or worse, get no idea at all. Okay, so we've figured out how to find it and identify it. Now let's move on to the most pressing clinical problem, its resistance profile, which is, to put it mildly, a moving target. The change we've seen over the last couple of decades is just dramatic. What used to be a generally susceptible bug is now, well, it's a resistant foe. Widespread high-level resistance to fluoroquinolones and macrolides is pretty much the norm now, and we know it's driven by specific genetic mutations. The good news, and this is absolutely critical for treatment, is that it's still universally susceptible to vancomycin and linezolid. But here's the kicker. When you're trying to interpret those susceptibility results, there are no official, species-specific EUCAST breakpoints for Corynebacterium Macginleyi. What does that mean? It means labs have to use surrogate breakpoints. Basically, we borrow the standards from other bacteria like Staphylococcus. This obviously creates uncertainty, and it means the lab and the clinical team have to talk and work together very closely to make the right treatment call. So, what does this bug actually do to people? Well, its clinical personality is kind of two-faced. It spans everything from a localized eye infection all the way to a life-threatening systemic disease. Okay, so it's most famous for causing eye infections, conjunctivitis, keratitis, that sort of thing. But we now know it's not just sitting there passively. Research shows it actively produces a powerful exotoxin that directly kills corneal cells and then kicks off a huge inflammatory storm by triggering cytokines like IL-1 beta and IL-8. This thing is a true ocular pathogen. And this is where it gets really scary. Beyond the eye, it's a serious nosocomial threat. In our most vulnerable patients, the severely immunocompromised or those with lines and tubes, it can cause absolutely devastating infections. We're talking bloodstream infections, endocarditis, ventilator-associated pneumonia. And its key weapon in this fight is its ability to form these tough protective biofilms on plastics, like catheters. So you've got this tough, resistant bug. How do you treat it? The number one rule, the one you cannot forget, is that you do not guess. Every single bit of therapy has to be guided by antimicrobial susceptibility testing. So let's look at a practical approach. In the Netherlands, they don't have specific guidelines for this exact bug yet, so they extrapolate from what they know about similar organisms. For any serious systemic infection, the first choice is IV vancomycin. Then, if the susceptibility report allows it, you can de-escalate to something like a beta-lactam, or maybe step down to an oral agent like linezolid for a long course of therapy. And when you're using vancomycin for these serious infections, this is the number you need to burn into your brain. The target trough concentration is 15 to 20 milligrams per liter. That's what you need to ensure you're hitting it hard enough to be effective. And this isn't just a local thing. The international consensus really mirrors this strategy. Vancomycin is your backbone, with linezolid and daptomycin as your main alternatives. The challenge gets even bigger with kids, though, because there are no specific pediatric guidelines, so treatment involves very careful weight-based dosing that we've had to extrapolate from adult data, always guided by drug levels. All right, last but definitely not least, since this is an opportunistic hospital-acquired pathogen, how do we stop it from spreading in the first place? You know, it really boils down to the fundamentals, right? 4 core things. Step 1, the most critical thing of all, rigorous hand hygiene. Step 2, apply standard precautions to every single patient, no exceptions. Step 3, if you're dealing with a multi-drug resistant strain, you escalate to contact precautions. And finally, step 4, be absolutely meticulous about how you manage invasive devices. Use them right and get them out the second they're no longer needed. So all of this leaves us with a really big, provocative question to think about. With tools like MALDI-TOF getting better and better, are we just getting better at finding an old enemy that's been lurking in the shadows this whole time? Or are we actually witnessing in real time the evolution of a new threat that's adapting to the pressures of our modern hospitals? You know, the answer to that question is going to come from the experiences of people like you, working in labs and on the wards every day. We would love to hear your thoughts on this. Have you seen this organism? What's your experience been? Share it with us in the comments below, and of course, subscribe to the channel to keep the conversation going. Thanks for tuning in.